I am Dr. Monica Christmas. I am an associate professor of obstetrics and gynecology and the director of the Menopause Program and Center for Women's Integrated Health here at the University of Chicago. And we are going to be talking all things menopause today. Go here. All right. My disclosures are I am also the associate medical director for the Menopause Society. And my objectives, we are going to define perimenopause and menopause because they are not the same thing. Identify common symptoms of perimenopause and menopause. There are some overlapping ones for those though. We're going to describe evidence-based treatment options for menopausal symptoms, including lifestyle interventions, non-hormonal therapies, and hormone therapy. You will be able to recognize clinical red flags and clinical scenarios that require prompt escalation. And then you should be able to apply effective intake, documentation, and patient-centered communication strategies to support team-based menopause care. Background information. What is menopause, right? Menopause is a normal, natural event. I am going to say that again. It is a normal, natural event that all women will go through if they are lucky to live long enough. Despite what social media would have us believe, it's actually not a medical diagnosis. However, it can be associated with bothersome symptoms that may seem worse than any medical diagnosis. And so, we'll get into that in a minute. But I do want to just highlight that this is a natural, normal event. It is defined by the final menstrual period, and that is confirmed after 1 year of not having cycles. Mother Nature has a very cruel sense of humor. Often people will get very close to that 1 year mark and they'll get a last hurrah period or two. Or during that perimenopause transition, as we'll discuss in a few minutes, there can be lots of menstrual fluctuation in people's periods during that time frame. Why does menopause happen? It happens because the ovaries stop making the reproductive hormones, specifically estrogen and progesterone. And that happens because of aging. And then when does it occur? It normally occurs between the ages of 40 and 58. And we can see that the life expectancy in most developed countries is well over 80 years for women. The median age of menopause, though, is about 51 and a half, 52. The natural range is between 45 and 55. So 95% of women will go through menopause between the ages of 45 and 55. So as you can see, if we live over, for most women living more than 80 years, pretty much we spend almost 40% of our lives in this post-reproductive time frame. And in the US alone, there are approximately 2 million women that will enter into menopause annually. So that's a lot of us, a lot of people. We'll level set with a little definition. So natural menopause is exactly what it sounds like. It's menstrual cycles stop from this natural process of the ovaries no longer making those making estrogen and progesterone anymore, the reproductive hormones, and it's defined after 1 year of not having a period. Induced menopause is menopause that is caused by either surgery, chemotherapy, radiation, or some other medication that causes insult to the ovary so that the ovary is not functioning to produce those reproductive hormones. Primary ovarian insufficiency, also called premature ovarian insufficiency, is characterized by irregular cycles. Often patients will go very long time without a menstrual cycle, and then it might kick in again. Not due to any other medical cause, though. This is characterized by loss of normal ovarian function, and it's in individuals younger than the age of 40. Premature menopause happens when the ovaries, it's not that waxing and waning like the primary ovarian insufficiency, where cycles are coming and going. Remember, I said they might go long periods without a cycle, but then they'll have one. For premature menopause, they just stop. So it's just menopause. because the ovaries are no longer functioning. And prematurely, that happens younger than the age of 42. Early menopause is between the ages of 40 and 44. And then late menopause is menopause that occurs after the age of 55, and that's about 5% of the population. When people talk about the menopause transition, that is the time frame where you start to experience changes in menstrual cycle. They're starting to become irregular, and it goes all the way up to the final menstrual period. And then perimenopause is that menopause transition, but it also is that full year after the last menstrual period. And then postmenopause is just after the last menstrual period. That's just the next phase of life. It's the postmenopause. And people always will ask, like, is it over yet? Am I done with menopause yet? And you're really not done with menopause because it's the post-reproductive phase of life. But I think what most patients are really asking is, when will I be done with symptoms? And most of the symptoms are most pronounced or most noticeable around the initial few years around the last menstrual period before it happens, and for a few years after the last menstrual period. For Black women like myself, we can have symptoms that last even longer. Our symptoms can last for 10 years or more. But on average, most people experience symptoms for about 4.5 to 5 years after the final menstrual period. And so what are the symptoms that people can experience? There are a lot of them. And one of the first symptoms in that menopause transition or perimenopause timeframe is changes to the menstrual cycle. Early perimenopause is having cycles that change persistently. This is not like a one-off, but this is persistent changes that last for more than 7 days or more than 7 days. So that could be having a longer cycle. It could be cycles spacing out. It could be them shorter or lighter, but it's more than a 7-day change. And then late perimenopause is late perimenopause is when you're skipping more than 60 days of cycles. And again, that's more consistent. Symptoms are more pronounced typically when people are in late perimenopause, but you actually can start to have symptoms like hot flashes and night sweats, changes in weight, mood swings, even in that early perimenopause timeframe. Somebody that comes in and they're, say, 33, and they want to know if they're having, they think that they're perimenopausal because they might be having, let's say, some night sweats. But if they're having a regular cyclic clockwork menstrual cycle, that's not perimenopause yet. We define it again by changes in the menstrual cycle. One of the other things that can happen in that perimenopause timeframe, most related to the fluctuation in hormone levels, is mood swings. And those mood swings or mood-related symptoms can be anything. It can be anxiety, could be depressed mood or sadness, can be irritability, or the most common thing is anhedonia, where people will say, I don't really think I'm depressed, but I just don't have the energy or the motivation to do the things that I once did. And these symptoms can be pretty severe and often can impact personal and professional relationships. Commonly, I'll see patients that are in danger of, at their jobs because they're either responding harshly to people that they work with, or they may just, even if they're not responding harshly, just thinking that I can't be at work crying all the time. And anytime somebody says something that potentially may hurt my feelings, I feel like I'm crying. About 40% of people during the perimenopause timeframe will have some sort of mood-related symptoms. And that prevalence goes up even higher if the person has had either anxiety or depression in the past, even if they've been stable for a long time. So it's really important that we ask about mood-related symptoms, especially during perimenopause. Most of them get better once they're menopausal because those hormonal fluctuations aren't happening anymore. And it's the fluctuation in hormone levels during perimenopause that tends to trigger the mood symptoms. I highlighted hot flashes and night sweats in blue because that's a really common one. Up to 80% of people will have hot flashes and night sweats. It's also included in blue as with the other symptoms that are in blue because those are things that hormone therapy is indicated for. Sleep disturbances, even outside of having hot flashes and night sweats. Commonly, people with night sweats will have sleep issues because the night sweat is waking them up at night. But even for people that don't have hot flashes or night sweats may also experience sleep disturbance in midlife. Joint pains, weight gain is extremely common. The weight can start again. That's a perimenopausal thing too. Often women will note that they start to gain weight a couple of years before their last menstrual period, and it can even happen for a couple of years after the final menstrual period. And for many people, it can be upwards of 20 pounds or more, which can be extremely upsetting because many of them say, I'm not eating any differently, I'm not exercising any differently, and it can be extremely distressful, as many of you have experienced when our patients come in. As we get older, and this is for men too, we lose muscle, and that muscle is replaced by fatty tissue. At midlife, much of that fat kind of deposits in the midsection. I can't think of a worse place for it to go from a vanity perspective, but also from a health perspective. And then things like vaginal dryness, irritation, itching, that can lead to pain with any type of vaginal penetration or bleeding. And if, of course, if something is painful, then decreased libido can happen as well, or decreased sex drive. But many women, even outside of having pain with intercourse, may report decreased libido post-menopause as well. And then urinary symptoms like increased frequency and urgency, recurrent urinary tract infections, thinning hair, changes to the skin, dry skin. Brain fog is a really common one. And then palpitations and heart racing. A lot of that happens when you're having a hot flash because the hot flash causes your pulse to go up. So some people will feel that as palpitations, and that can trigger more anxiety as well. That all sounds terrible, I'm sure. Um, there is not one menopause syndrome that every single person has. There's some people that are really fortunate, they get very few symptoms at all. And then there's people at the other end of the continuum that get all of the symptoms. And so we manage people accordingly. And in fact, even if somebody that may report that they're having mild symptoms, but if those mild symptoms are really disrupting their quality of life, then we want to manage them and treat them as well. In terms of how do we evaluate patients, I broke it down into three categories. One is I want to always think about and encourage you all to think about when you're taking the history and triaging the patients, is to establish what their reproductive stage is. Is this somebody that's perimenopausal? Is it somebody that's menopausal, meaning they have already met that 12 months of not having a period? Or are they postmenopausal at this point? And really, I should have put a fourth up there. Are they in the reproductive stage? Because they're still having a regular menstrual cycle. And then it's really important to establish what their symptom assessment is. I want to know, are these symptoms frequent, or how severe are they? How much is it impairing or impacting their quality of life? And so in particular, I gave you that slide previously that had all those symptoms on it, but I kind of zoned in here are some of the most common and prominent ones that patients will come in with. The vasomotor symptoms, meaning the hot flashes and night sweats, sleep disturbance, mood-related symptoms, cognitive changes, the brain fog, the genital urinary symptoms, musculoskeletal things like joint pain and aches, and then any of the sexual health concerns. And then the last part of it is just getting a good menstrual history, especially for those people that are in the perimenopause range, understanding what is their cycle length, how variable is it? Are they having heavy or prolonged bleeding? Is there bleeding in between menstrual cycles? And is there any postmenopausal bleeding? And I put a little red flag by postmenopausal bleeding because we always want to establish um, the diagnosis and do a workup in anybody that's having postmenopausal bleeding. Sometimes it is true. It can be due to being a new start to hormone therapy. But even then, we want to make sure that there are not any other underlying medical comorbidities that might be causing the postmenopausal bleeding. Especially in midlife, the incidence of endometrial cancer and hyperplasia goes up. And I certainly don't want to miss that diagnosis, just making the assumption that their abnormal bleeding is because of menopause. Then other important aspects of the history, understanding what or recording what their personal medical history is, their surgical history, family history, key areas of focus. Did this person have a hysterectomy, or did they have their ovaries removed, the oophorectomy? Is there any personal or family history of cancer? Have they ever had any thromboembolic event like a deep vein thrombosis, a pulmonary embolism, or a stroke? Even if they haven't had one, did their parents, and how old were they when they had them? Cardiovascular disease and risk factors, especially smoking and heavy alcohol use, liver or renal disease, migraines with aura, and do they have a history of osteoporosis or a fracture history, or in their mother or sister? Medications and therapy review. It's really important to know, are they on any current hormone therapy or hormonal birth control? What else have they done? Have they tried any of the non-hormone therapies to treat their menopause symptoms? Are they using any over-the-counter supplements? A lot of times patients don't think about those over-the-counter things as real medications, so they might not tell us that when you ask about medications. So it's important to actually probe that and say, okay, I understand you're not on any prescription medications, but are there any supplements that you're taking? And then are they on any other form of contraception? And then lastly, getting a good preventive care and risk assessment. Menopause happens at a time that, it coincides at a time that we are aging. And there are a lot of things that happen just due to chronological aging that have nothing to do with menopause. Everything isn't all menopause. So making sure that we don't lose focus of these preventative care strategies and testing that we ask patients to have, like their pap smears. When was your last mammogram? When was your last colonoscopy, or have you ever had a colonoscopy? It used to be that we started colon cancer screening at age 50. That age limit has been decreased to 45 now. Has the patient ever had a bone density scan, and when was the last one? And then any relevant labs, lipids, hemoglobin A1C, a comprehensive metabolic panel, complete blood count, and thyroid function testing are all important as well. And then for the physical exam, it's important to get their weight. I like knowing what their BMI is, so thank you and kudos to everybody that makes sure that information is put in, and then what their blood pressure is. Sometimes a breast exam is appropriate, as well as a pelvic exam. Anytime a patient reports having any genital urinary symptoms like the vaginal dryness, the itching, the burning, certainly any bleeding or pelvic pain, that patient should be undressed so that the physician can do or clinician can do a pelvic exam on them. Laboratory testing, meaning checking hormone levels, and I know your in baskets are all full with patients requesting labs. And somebody that undergoes or is at the natural normal range of menopause that are having symptoms, labs are really particularly not helpful, especially during perimenopause, because most times they're going to be normal. And sometimes in perimenopause, the estrogen level is even higher. That contributes to that fluctuation earlier that I was talking about. Hormonal labs, I should say in particular, can be helpful for a patient that is younger than the natural age of menopause. So if I have a young person, 25-year-old, or anybody that's under the age of 45, then it is useful, because I want to understand, is this polycystic ovarian disease? Is this early or premature menopause? Is this some other endocrine abnormality that is contributing to their menstrual changes? But anybody that's in the natural normal range, labs are not particularly helpful, and we don't check them. Lab values actually don't indicate how severe symptoms are going to be, and they actually don't show us whether or not the patient has been successfully treated. We manage these things clinically. You can have somebody that's perimenopausal that has absolutely normal labs when you check them, and they can be highly symptomatic. We'll watch them have hot flashes and night sweats. And then you can have somebody that is clearly menopausal. They haven't had a period for 4 years, and they're not having any symptoms. And when you check their levels, there's zero estrogen. So as you can see with that, people are the hormone levels can be variable and they don't always correlate with symptomatology. But laboratory testing to get, because we may want to rule out other causes of the patient's symptoms. So I put them here. So again, thyroid function testing, CBC, iron studies, CMP, lipids, hemoglobin A1C, when it's appropriate. And especially when we want to rule out other causes for their symptoms. And then a CMP, that comprehensive metabolic panel, specifically for the liver function testing for any patients that are on fezolinetant or elinzanetant. Those are two new drugs. They're called NK3 and NK3-1 receptor antagonists. That's your Veoza and Linquet. Those are the newer ones. For fezolinetant, patients need a baseline CMP to show that their liver and renal function is normal. And then they will have monthly CMPs for the first 3 months. As long as they're normal in that time frame, then they'll get spaced out every 3 months for the remainder of the year. And then for elinzanetant, that's Linquet, you'll have a baseline CMP, and then they only need one check at the 3 month mark. If it's normal, you don't have to check it again. So I know you guys always are probably getting questions from patients about whether, what was my CMP? Do I need to do it again and when? So that's the time frame. I talked about breast exam when inappropriate, and certainly a pelvic exam when there's any bleeding or pelvic pain. And then treatment approach. So how do I think about it with patients? One of the first things I always counsel patients about is diet, exercise, and self-care. I don't have any medications that actually supersede those things. So above all, helping people be healthy as they are aging. Because remember what I said, menopause coincides at a time frame where we are aging. So it's vitally important that we are intentional about what we choose to fuel our bodies with, and we are meticulous about how not only we exercise our bodies, but how we're using and exercising our minds too. And then making sure that there are self-care strategies where we're taking time. I keep saying we because I'm in that menopause age range myself and completely understand how important it is to take self-care time, especially during a time frame where, as I said, 40% of people can have some sort of mood-related changes. Mind-body therapies, cognitive behavioral therapy, hypnosis, and mindfulness have all been found to help with hot flashes and night sweats, but also help with anxiety and mood disorders, as well as sleep dysfunction too. We're really lucky here to have Dr. Maggie Collins that does cognitive behavioral therapy, not only for insomnia, but also for vasomotor symptoms, as well as Dr. Fabiana Arujo in our other in the BMed clinic. There are some online modalities too, where patients can teach themselves about cognitive behavioral therapy that are very good if they don't have access or the ability to work with a licensed psychologist. And then there are non-prescription options like over-the-counter products. Generally, especially the ones that are promoted as being treatments for hot flashes and night sweats, like black cohosh, evening primrose oil, chasteberry, some of the other vitamins alone or in combination with one another. When you test them against placebo, or they haven't been shown to be more effective. So I don't normally recommend those over-the-counter products, but if a patient comes in and they think that they're working, then I don't stop them. I do let people know that, placebo has like a 30% effective rate, but even if it's a placebo effect, if the patient is feeling better, then we go with it. Some of the over-the-counter vaginal moisturizers and lubricants, though, have been shown to be beneficial in managing some of the vaginal dryness and pain with sex symptoms. And then the prescription medications. So hormone therapy and non-hormone therapy options, which I'm going to spend some time on now to talk about, because I know that those are the ones that a lot of patients are calling with questions about. So indications, I'll start for hormone therapy. These are the government-approved indications. So the first is for moderate to severe hot flashes and night sweats. The second is moderate to severe genital urinary symptoms, so the vaginal itching, burning, pain with sex, urinary frequency, urgency, recurrent urinary tract infections. And then anybody that goes through premature or early menopause, that's earlier than the age of 45. And then for osteoporosis prevention or management in those that have osteopenia. Now, even though those are the only indications, there are some downstream benefits of hormone therapy. I said it earlier, somebody's having really debilitating night sweats that's disrupting their sleep. Then if we give them hormone therapy or any of the other non-hormone therapy options that help reduce hot flashes and night sweats, then they will sleep better. And if you sleep better, you probably have less brain fog. You may be more energetic, and you may even not have as many mood-related symptoms if you slept better. So even though hormone therapy isn't directly to treat brain fog, or it isn't a direct treatment for, say, weight loss, if you're feeling better, having more energy, then you may be more likely to exercise and some of the other healthy things that will make you feel better and lose weight. I broke down here just the two categories. So there's non-hormone therapy options, and under that category, there's certain antidepressants that have been shown to help reduce, in particular, hot flashes and night sweats. Antidepressants in general help with anxiety and depression. That's what they do. And then many of them also can help with sleep too. So there are several different benefits that might happen from being on an antidepressant. Antidepressants are not considered the gold standard for, antidepressants are not necessarily considered the gold standard for management of hot flashes and night sweats because you only get about a 45 to 65% reduction in symptoms, whereas hormone therapy has an 80% or greater efficacy. Gabapentin is a neurologic agent that we use for chronic pain syndromes like fibromyalgia, multiple sclerosis, even like arthralgic kind of symptoms. It also has about a 40 to 65% efficacy for reducing hot flashes and night sweats. So again, not as much as hormone therapy will. Gabapentin also, though, can help with sleep and also can help with mood. So for people that can't be on hormone therapy or choose not to be on a hormone therapy option, it could be beneficial. Oxybutynin is a medicine that we use for overactive bladder. It has about a 70% reduction for managing hot flashes and night sweats, but it also has some other side effects like dry eyes, dry mouth. And in older people, it has been found to be associated with higher cognitive risk. So, we use it sparingly. In a younger person, it's probably okay, especially if they have leakage of urine. But if they're not having urinary symptoms, the side effects from the medication probably outweigh the benefit of it. And then the neurokinin receptor antagonists, again, that was the Veozah and Linquet that I spoke about earlier. They are non-hormonal treatment options for managing hot flashes and night sweats and work very well. And they can be used like the others in patients that either have a contraindication to hormone therapy or do not want to be on hormone therapy. And then for hormone therapy, there are two classes. There's higher dose systemic hormone therapy, meaning it's absorbed into the bloodstream. And then there is local low dose estrogen therapy that has negligible, so pretty much no systemic absorption. It is just absorbed at the level of the vaginal mucosa. And so for the systemic hormone therapy, those are the treatments that we're using for managing hot flashes and night sweats. It's also the treatment that we're using for protecting against the progression from osteopenia to osteoporosis, so for bone health. We also want to treat patients with systemic hormone therapy that go through early menopause. So anybody that goes through menopause earlier than the age of 45 should be on hormone therapy to protect their heart, their bones, help prevent against dementia, and they should be on the hormone therapy until they would have reached the natural age of menopause. And again, the natural range of age of menopause is between the age of 45 and 55. There's estrogen alone options, and that would be oral tablets. The transdermal options are patches, gels, sprays, and a vaginal ring. And you can use estrogen alone in patients that don't have a uterus anymore. They had a hysterectomy. If the patient still has their uterus, then they need both estrogen and progesterone, because estrogen can cause the lining of the uterus to thicken, and over time that can increase the risk of hyperplasia or uterine cancer. And again, that's far worse than hot flashes and night sweats. So for people that still have a uterus, they need to be on estrogen and have a progestin. There are estrogen and progestin combination options. There are patches that have both estrogen and progesterone in it. And there are oral pills that are combinations of estrogen and progesterone. And then there's one oral pill that's a combination of estrogen and something called a SERM, a selective estrogen receptor modulator. And that SERM or in the pill takes the place of the progesterone. Some of you may have seen me or others prescribe Duovi. That is that hormone therapy pill option that is a combination of estrogen with something called beta-doxyphene, the SERM. And that tends to sometimes have less side effects, especially breakthrough bleeding, than some of the estrogen and progesterone options. The estrogen and progesterone combination options, and even that estrogen SERM option, there's now a lot of doses. And sometimes patients want to be on either a higher dose or a lower dose of estrogen, or their insurance won't cover. That's another reason, won't cover one of the combination drugs. And then we have to separate them out, meaning we have to give them estrogen one way, and then we have to give them the progesterone another way. Progesterone can either be, like I said, with a progestin IUD or with an oral progestin pill. And I've already went over all the various options with estrogen. One of the things to note, though, is that when you use a transdermal option, so the patch, the gel, the vaginal ring, or that spray that you spray on your skin, those are absorbed through the skin and they get into the bloodstream. They don't have to be metabolized in the liver. When you swallow a pill of hormone therapy, it actually does get metabolized in the liver and it bumps up your body's clotting factors. That could increase the risk of one's risk for a blood clot, so like a pulmonary embolism or DVT, and could increase the risk of stroke. In a young, healthy individual, it's probably not really a concern, and taking an oral form is fine. But in older people or in anybody that already has some cardiovascular risk or has clotting or stroke risk, then we would want to avoid oral pills and only give them a transdermal option. And then for the local low dose vaginal estrogen, there's a vaginal tablet, a vaginal insert, vaginal cream, and a ring. The tablet, the insert, and the cream are administered twice a week. And the ring goes in place, it stays in place for 90 days. At the end of 90 days, you pull it out, throw it away, and then put a new ring in. So that one's kind of nice because you don't have the fuss. And then I want to end with, what is the team approach to care? So as a medical assistant, what is your role in managing and assisting with managing the patient? And then what's your role as a nurse too? So from the medical assistant, you're the first person outside of the patient concierge that check the patients in. You're the first person that the patient encounters. You are initiating the history. The data, the information that you collect really impacts strongly how the clinician is able to smoothly go through the patient visit. So the more information that's able to be in that triage form in your chief complaint and taking their history, the better. So taking a comprehensive history is a first step, and then making sure that not only the room, but the patient also is prepped based on their presenting complaints. As I said earlier, if somebody has pelvic pain, certainly any vaginal bleeding or any abnormal vaginal discharge, that patient is going to need a pelvic exam. Understanding and helping the provider know, has that patient had a recent mammogram? Are they up to date with their pap smears? Have they had that bone density scan? Have they have a colonoscopy? All of those things are really important as we are caring for a midlife patient and beyond. And then for the role of the nurse, if you're able to be in clinic, helping to support with reviewing educational materials with the patient. And that's one thing I didn't mention in part of the prepping the room. as the role of a medical assistant, you can grab some of the menopause handouts and actually give it to the patient, especially if the provider is running behind. The patient can be looking through that information. And then if nurses are available to help support that, answering any questions that the patients may have. And then assisting with triaging when patients call. I rattled off a number of different medications and treatment modalities. Most patients are going to need some sort of follow-up visit, right? It's not easy if they call and say, well, I don't want this anymore, or I decided I want to be on hormone therapy. I'm not sure what hormone therapy they want to be on, right? Do they want to be on a patch? Do they want to be on a pill? Would the ring be appropriate? Would a non-hormone therapy option be appropriate? So level setting with patients and helping to set their expectations are helpful, that this isn't oftentimes just a quick phone call. Those patients that call that are having abnormal bleeding, of course, we all want to be able to say that, oh, you just started hormone therapy, it's probably because of that. And most likely it is probably because of that. But those are people that we still need that should be evaluated and should be seen to make sure there aren't any other underlying causes of the bleeding. Does not mean that it's a cancer, but that's certainly something that I don't want to miss. And then refilling medications when appropriate. This one comes up a lot. Sometimes patients lose track of time. They realize they're almost out of their medication. They call to make the appointment, and the provider doesn't have anything for 3 months from now. If they're already on the medication, many of us, it's reasonable to go ahead and refill it. Certainly, if you're, sending a quick note to the provider saying, hey, is it okay if I refilled it? The patient hasn't been seen, was due to see you last month. They weren't able to get in, but they do have an appointment with you in 2 months. So I'm just going to give them a 3-month supply. Most of us are completely fine with that. And then, at the end of, just for everybody, we are all part of the patient's shared decision-making process. We all bring something valuable to the patient care encounter. None of us can take care of the patients without each other. So I am extremely appreciative, as are my colleagues, for everything that each and every one of you does to help us be successful, but to also give the patients the exemplary care that they deserve and want to receive. So I am going to open it up to questions. I just want to, in case I forget, the next evening round on pelvic pain will be given by Dr. Ansia Patanwala on Monday, February 16th. And then we will be getting the perinatal depression screening evening rounds lecture up and soon that Dr. Nunes will be doing. You will get notification for when he will be giving that lecture. So I am going to stop sharing my screen right now. And does anybody have any questions? Somebody's got to have a question for me. Should I start making up my own questions? I did that good of a job? All right.
I
Well,
think you did. I
oh,
think you did.
well, thank you. I'll just leave. I think that I will just say that there is not one menopause syndrome that every single person gets. It is a variable experience. As I said earlier, some people get every symptom that there possibly is, and some people get very few, if any at all. And patients are really, really inundated right now with a lot of information through social media. And as we all know, social media, there's some good things. I think it's nice that it's a place that people can get information. They can see that they're not alone. It can be empowering, but there's a lot of mis and disinformation out there. Really because menopause has become monetized, everybody and their mama are trying to capitalize off of it. And so with that, there's so much information that it really is, really important for us to be able to give them appropriate information, to do it respectfully, to listen to what they're saying, but also just to make sure that none of these things are without harm. So even though hormone therapy is probably safe for most people, it's still a medication that confers some risk.
Um,
Yeah.
Hi, Dr. Christmas. This is Yasmin. I actually have a question. So you were mentioning for primary ovarian insufficiency, how usually that happens before the age of 40 years old.
Mhm.
I have a question regarding that. Is that like genetic or how does that happen? I have like a friend that actually she's going through that, and I just want like more information about that.
Yeah, it's a great question. Most times we don't know
Oh, gosh.
why the person went through primary ovarian insufficiency. Part of the workup is to do a genetic assessment to see if there's any underlying genetic things that may have contributed. But most time we don't actually have an answer.
Okay, makes sense. Thank you.
Yeah.
There's
And
a
then it looks like
question
another
in the chat.
question.
Okay.
Oh, yeah. If a patient is perimenopausal, when can she stop birth control? If that patient's blood pressure is normal, there's no other cardiovascular risks that we're worried about, and they're doing fine, I keep them on it until they're 55. Because by 55, 95% of people will have met the definition of menopause. If it's a curious person and they just want to know where they're at, then we can stop it and see where they are. But if it's somebody that says, "Oh my goodness, I remember how bad the hot flashes were, or I remember how bad my mood swings were," or they're just not interested and they like being on something, then I'll just roll them over to hormone therapy at that point. But birth control is a really good option for people that are early perimenopause because those people are still getting periods. And if you put many of them on hormone therapy, they're going to have really irregular bleeding. And those are the patients that you all are tired or answering messages from me and my colleagues because they're the people that I've been bleeding for 30 days or more. So hormonal birth control actually can be very helpful in perimenopause. And then will the literature be on a drive where we can access it and send new patients while waiting for the appointment? Um, we do have the menopause booklets. I've got a number of handouts that are from the Menopause Society. We can always that we can distribute because they're in clinic and we can give to patients while they're waiting. Um, in terms of a drive where they can access, are you meaning like videos that they could look at?
No, like so when I'm making an appointment for someone to need to see you and their next available appointment is not that soon, but they have a lot of questions and don't know where to start. As you said, it's like a lot of different things that's out there that they just don't know what to do. Is there something like that we can access this on the drive? Like Eurogyne has some literature that's on their N drive or U drive, and we just pull that information off there and we send it to them through their My Chart.
Yeah,
So
we
when they
should create.
come and
That's a
see
great
you,
idea.
so when they come and see you, at least they have an idea of what the expectation is and what they want to talk to you further about instead of you going like from zero to A to Z, where at least they can meet you at M and say, "This is what I want to talk about."
I love that idea. I'm gonna connect with you offline and take
Okay.
a look at what Eurogyne has and see how we can do something
Okay.
like that. I think that's
Sure
excellent.
thing.
The other thing that I've been thinking about doing, we're going to probably try to launch soon, is almost like how the midwives do with the centering, but it'll be a menopause group intake thing too, where they can get information as well, and then they would have a follow-up appointment to discuss what treatment they actually want. So hopefully that might be helpful and help get more people in sooner. And then we've got more providers too. Dr. Melinda Lukens is menopause certified, Dr. Um, Farah Alvey, Dr. Anthony Gentile, and Dr. Sarah Wagner. And Mary Kay Burke is one of the midwives who also has her menopause certification. But even beyond that, I mean, menopause Many of our providers, even if they aren't menopause certified, are comfortable seeing menopausal patients that are symptomatic. So we have lots of places we can get patients in.
That's great. I didn't know Dr. Gentile and Dr. Wagner were. So that's great.
Yep. And they're on the website has been updated. So the menopause program page is also a place that we can send patients to. There's information on those pages as well as some videos too. And then it looks like it says for a patient that just started hormone therapy, on average, how quickly would therapy be expected to help with symptoms before trying a different medication? Hormone therapy works pretty fast, actually. It does. So, when I say fast, within it can be kind of miraculous sometimes within a few days. When we're talking about managing hot flashes and night sweats, what I see most often is people will say, "Oh yeah, my hot flashes and night sweats are gone, but my libido was still low." Or I'm still gaining weight. Hormone therapy doesn't help with those things. Or I still have joint pain. That's a big one. Some people will notice maybe a slight improvement in joint pain because there are estrogen receptors all over our bodies, even in our joints. And when you start hormone therapy, sometimes joint pain might get better, but in general, it doesn't. So that's where the level setting happens of, well, we put you on hormone therapy for your hot flashes and night sweats. I didn't ever tell you that it was going to help with libido, but I do care about your libido. So let's talk about that. And there are some treatment strategies and options that we can employ to help with those symptoms as well. And then, is it okay to schedule new patients with with Dr. Wagner and Mary Kay? It's absolutely okay to definitely schedule new patients with Dr. Wagner, and as well as with Mary Kay as well. I hope I don't think I missed the question.
Sorry, I had a question. I was
Yeah.
just curious about for patients who have like a family history of breast cancer or they know they have like a BRCA mutation, how their like choices of birth control are affected. Like if the options that you discussed, if all of those are available or if there's certain limitations.
Yeah, so if a patient is BRCA positive, no matter if it's one or two, and they themselves have not had breast cancer. So they don't have a breast cancer history, but
Mhm.
they have a genetic mutation, one of the BRCA mutations. Most of those patients are at a higher risk for developing breast cancer, some even ovarian cancer. And so
Mhm.
many of them are going to undergo early oophorectomy or hysterectomy with oophorectomy, which is going to put them into early menopause. And so they actually should be put on hormone therapy
Mhm.
until they would reach the natural age of menopause, and then they would be taken off. If somebody, though, actually had a personal history of breast cancer, so they themselves had breast cancer, that
Mhm.
gets a little bit trickier. The guidelines would be that we should try to get them on a non-hormone therapy option first. And if their symptoms were still pretty severe and not mitigated by being on one of the non-hormone therapy options, that's where shared decision making comes in. For somebody who has a very remote history of breast cancer, it was not an estrogen receptor positive breast cancer.
Mhm.
They've had a mastectomy. I still can't say that they're at zero risk because even when people have a recurrence, it's rarely the same type of cancer that they had the first time. So even if their cancer before was estrogen negative, when they have a recurrence, it might not be estrogen negative. But for some patients, they'll say, I understand that risk and nothing else is working, and my quality of life is so bad that I really want to be on hormone therapy. The
Mhm.
question then becomes on how long do you keep them on it? Because, do we keep you on it forever? Do we keep you on it until For people that are under the age of 60 or within 10 years of the onset of menopause, the risks for most people tend to be low. And that's in the general
Mhm.
population. I'm not talking about people with a history of breast cancer. But
Yeah.
for individuals that are over the age of 60 or more than 10 years from the onset of menopause, the risk can start to outweigh the benefit. And there are higher associated risk of heart disease. There's a higher associated risk of those blood clots like stroke and DVT. There's a higher associated risk of stroke, and there's a higher associated risk of cognitive decline. And in individuals that are on estrogen and progesterone, there's a slight increased risk of breast cancer as they get older too on hormone therapy. So it's a pretty nuance, but to answer your question, in general, we probably would not want to put people with a history of breast cancer on systemic estrogen therapy or hormone therapy. We would want to try some of the non-hormone therapy options. But for local low-dose vaginal, just the vaginal estrogen therapy, that's fine. Because remember, I said local vaginal estrogen is not being systemically absorbed. So even in somebody that currently has breast cancer or hasn't had a blood clot in the past, that would be okay for them to use local vaginal estrogen.
Okay, gotcha. Thank you.
Okay. All right, people. Thank you for being so attentive. And thanks for all the help in helping to take care of our patients. If you think of any other questions, you know where to find me, ask anytime, and I'll see you in clinic.
All right. Good night.
No, thank you.
Thank you.
Good night. Thank